So now the turbinates, this is another huge area. You'll see various different options. Different surgeons have different ways of dealing with this. Different patients have different experiences with it. And traditionally, what they used to do 100 years ago was they removed the whole thing. So remember that wing-like structure? They just cut out the whole thing, and patients were breathing much, much better. But then months or years later, they come back saying, I can't breathe. And the reason is you need a little bit of resistance to perceive that you're breathing. Okay, so the turbinates are there for function. So then we went to partial removal, and then now we've gone to more conservative options where we go underneath the mucous membrane, and you have these special instruments to scar or remove the tissues or even bone.
So how do they fix those people who couldn't breathe?
That's a challenge. Unfortunately, we don't see that many people anymore, but what you have to do is you have to put a little implant in to kind of create a bulge. And that itself doesn't work that well either. So these are what are called the nasal cripples. They have chronic dryness or irritation, infections. Okay. So you're going to see all these terms, somnoplasty, radiofrequency, microdebrider, turbinate reduction. There's all these terms. These are more technical details. But the general rule is you want to be on the conservative side. And what I do is I tend to just, initially when I first start, I just kind of scar the blood vessels on the inside, and I do a really good septoplasty. And that's usually good enough, so I don't have to cut or remove any part of the turbinates. But sometimes I have to go back and take out more.
So that's the same?
At the same time.
1 or 2 days?
Yeah. Usually I do both together. Okay. Now, nasal valve collapse, this is a very common condition. As I said, most people will have some degree of this. This is where your nostrils cave in. And we talked about the column maneuvers and the nasal dilator strips. And I mentioned how I differentiate, am I going to do this alongside the septoplasty or do it as a stage procedure later on in case the septoplasty doesn't work. But there are various different ways of treating this. The traditional recommendation by most ENT surgeons and plastic surgeons is what's called a nasal valve reconstruction. It's like an open rhinoplasty approach. It's a functional reconstruction, basically. You have to open up the nose like a standard rhinoplasty, and you put pieces of cartilage that you take from your septum or your ear, and you put it in pockets right there. So you kind of, as it heals, it scars and tightens the nostril so it doesn't cave in. So it's a relatively big operation, although it's pretty straightforward, but it does have a way of making your nose a little wider, because when you're adding support to the nose, when you're adding structure, you have to make it wider. So that's the side effect, the downside of this operation, but it works for the most part. Along with the fact that if you don't have enough septum in your cartilage in your septum, you have to take it from your ear. Okay. Now, I've been doing a variation of this. It's a minimally invasive procedure where instead of opening up your nose and put cartilage here, I attach a suture underneath the bone, underneath the eye. Let me show you the picture. I started doing this a couple years ago. So make a little a stab incision right there in the eyelid crease, and that heals really well without scarring. Attach a suture to the bone right there. We tunnel that under the skin, grab the part of the nostril that's collapsing, loop it back up. So what you're doing is you're suspending the nostril from underneath the skin so it doesn't cave in. So the beauty of this is it's a minimally invasive procedure. It takes about 10-15 minutes per side. It can be done under local anesthesia in the hospital though, because it's an implant. No, you go through the skin here. You come out through the nostril, but you bury it underneath and go back up. So everything's done under the skin.
That's like a permanent breather.
Yeah, exactly.
So what would that do for my apnea?
Again, this is for nasal breathing.
So I breathe better, but it might not.
Right.
Might it do something for the apnea?
It may, again, it's that 10% rule.
Right.
Yeah. And there are also variations of this. You have implants, these butterfly-shaped implants you put on top of your nose, and other minor variations. But this is, I do these two. And so in the small chance that this doesn't work, sometimes the body just overwhelms the suture. It just collapses even despite the suture. Then we have to go back and do the standard procedure, and that works pretty well. Okay. And then sinus surgery, this is, sinus, you have to realize you don't have just one sinus, you have 4 pairs of sinuses. And so when you do sinus surgery, it's usually of the maxillary sinuses and of the ethmoid sinuses between the eyes, but you can also have sinus surgery in the frontal sinuses or in the back of your nose called the sphenoid sinuses. So there's, depending on where the disease is, you have to address all the different areas. And if you have any kind of chronic sinus disease, you're going to have congestion or polyps, postnasal drip, inflammation. Okay. And this is a little more extensive than the septoplasty, about 1 to 3 hours under local or general anesthesia. You're off for a couple more days. Usually I don't use packs, but sometimes I'll use a dissolvable pack, so you don't have to take it out. Okay. And then CPAP and nasal congestion. This is a major issue for many of you here. As you know, you can change the humidity settings, and for most people when you first start, you don't use enough humidity, so humidity is very important for the nose. So that's something that you need to kind of play around with to find your optimal humidity setting. And you realize that that's going to change also depending on the atmospheric humidity levels too. Suboptimal pressures. Now, this has to do with more CPAP compliance issues. If your nose is stuffy or if you have a leak, then your pressure is not going to be optimal for you. So then your apnea, hypopnea index goes up and you don't feel well. And so that's why having a well-functioning nose is so critical. Many people also will experience ear issues because the air can kind of get pushed into your ear. When you swallow, it opens the eustachian tube and you get your ears get full. So for many people, that's not a major issue, but for some people, it can persist. So what you can do is to either lower the pressure, or if you have nasal congestion, by treating the nasal congestion, it can get better too. Let's say you've run through the whole gamut of recommendations that I made and you're still stuffy at night. And let's say you're treated optimally for your sleep apnea and you're still stuffy. Then I guess the other option is to get evaluated for surgery if it bothers you to the point where it affects your quality of life. Okay. All right, so I'm going to skip this. Okay, so I'm going to finish off here. Just to let you know, I wrote this book called Sleep Interrupted. I have a couple of limited copies available for sale at the table over there after the talk, and I'll just open it up for questions. Let me start from the back over there. Yes.
What are your thoughts on prescription nasal sprays? I really didn't hear you mention that too much.
Well, the most common prescription nasal sprays are the topical steroid sprays, and then there are also antihistamine sprays and Atrovent, which I mentioned before. I think that's a useful medication, especially if you have allergic rhinitis. And the way they work is you have to use it on a regular basis for it to work well. Think of it more as a prophylactic medication. Whereas the antihistamines work a lot quicker, so either the pills or the sprays. So it can be a useful adjunct, especially if you have allergies, but it'll work to some degree even if you don't have allergies.